All right, thank you, everyone. So I'm going to talk about the exciting topic of diagnosis of infection. So my name is Antonia Chen, 陈韵如。我在美国出生，所以我用英文讲比较简单一点。I'm at Brigham and Women's Hospital in Boston. The diagnosis of infection is different in every country. In the United States, we use something called the AAOS, or the American Academy of Orthopedic Surgeons, definition of infection. Every time you're doing a revision case, always get ESR and CRP, minimum. What happens if it's high? Then you do a puncture. You aspirate the knee and take fluid from the knee. There's no role for bone scan, CT scan, or MRI. Oops. ESR is high sensitivity but lower specificity. The number you want to use is 30 is the magic number. For CRP, it's high sensitivity and high specificity. If you can only get one, CRP is better than ESR. The problem with ESR and CRP is that it's high in the body for many reasons. If you have a cold, if you have an infection in your urinary tract, basically anything else that could be causing problems can elevate ESR and CRP. So it's non-specific. So it's not enough to have ESR and CRP. So if both ESR and CRP are normal, then you're probably okay in 90% of times. But if ESR and CRP are high, then the puncture makes a big difference. Now, how can you tell if a patient's infected? All the surgeons here know that if a patient comes in with a red, hot, swollen knee, they're more likely to be infected. So we look at physical symptoms of patients to see what they're doing. We also have other varieties that we can do. So if you take a puncture from a patient, you want to ideally have them off antibiotics for 2 weeks. So in the US, and I think in China too, what happens is doctors, medical doctors, put patients on antibiotics. That's not good. So you want to stop antibiotics, wait 2 weeks so you can improve the diagnosis of infection. Hold cultures for 14 days and don't use swabs, use tissues. If you do get cultures, don't just put it in a tube and send it down. What you want to do is get the blood culture tubes and fill them because it improves the sensitivity of diagnosis. What we have to do is tell our lab that we need to hold it for 14 days for aerobic and anaerobic culture. But here in China and in Asia, tuberculosis is more common, so those type of cultures should be held for 6 weeks. It's very hard to diagnose tuberculosis on culture, so you want to keep it much longer. The problem with culture, though, it's highly specific, but very low sensitivity. So you can't just use culture alone. A lot of doctors say, well, culture's positive, they're infected. Well, that's positive, yes, but just because it's negative does not mean they're not infected. The other thing you want to look at is synovial cell white cell count. This is much more specific than blood white cell count. So high sensitivity and high specificity for it. We used to send, instead of just culture, we would do gram stain. Gram stain is not enough. The problem is you put it on a stain and the person who reads it may not be the same person each time. So you may not get a good read for it. Systemic or blood white blood cell count, also not good. There's no evidence to use CT scan or MRI. You can use nuclear imaging. We call it tagged white blood cells. You take the blood from the patient, you tag white blood cells, and they actually go to the place where infection is. So the problem is there's no good definition for infection. So because of that, the Musculoskeletal Infection Society, where I'm president right now, it actually came up with a new definition. And the definition started with major criteria. So if you had a sinus tract, what's a sinus tract? Well, if you can see metal, then it's a sinus tract. That means they're definitely infected. So if there's a sinus tract, they're infected, no questions. If you have 2 positive cultures, and this is a little hard, you need 2 positive cultures at different times. So you aspirate them once and you aspirate them again, or you aspirate them and puncture once and then take tissue the next time. If they're both positive for the same organism, they're infected. The minor criteria are probably the most important, And we'll do a case discussion later, kind of highlighting how important they are. So ESR and CRP are high. Remember, it's ESR and CRP, not just one, but both. White blood cell in the synovial fluid, above 3,000. Polymorphonucleocytes in the synovial fluid, greater than 80%. Positive frozen section, and 1 positive culture. So this can be before surgery. So let's say you have 1 positive culture before surgery. If you're looking for the second positive culture, don't forget, take tissue, not just fluid. When you take the tissue, the more you take, the better. But I've gone to operating rooms where they're taking 11 samples. You don't need that many. That's too much. If you do 3 or 5, it's good. Why an odd number? Because if you have only take, say, 4 samples, if 2 are positive and 2 are negative, then you don't know. But if 1's positive and 2 are negative, you're more likely to think it's negative because it could be a false positive. The accuracy is high when it comes to the biopsy or tissue sample collection. In frozen sections, if you have a good pathologist in your hospital, then what they do is they take the tissue and they can slice it right away and they stain it right away. It's very useful if you're in surgery at the time because they can do it right at that time. If you have 5 to 10 white blood cell count per high-powered field, so it's one area at 400 magnification, and people say you're infected. It's very good for ruling in. So if it's positive, pretty good sign. But it's not good for ruling out. The reason is you can have inflammation. So metal on metal in tips, that causes inflammation. And because of that, this is not always the best test. So we had one definition of infection, the Musculoskeletal Infection Society. We wanted to do another definition because time passed and things changed. The International Consensus Meeting was pulled together in 2013 in Philadelphia. And I know many people in this room are going to be coming to 2018 Infection Consensus at the end of July. Same thing as last time, except we're going to have over 800 people coming this time. So it's a very big group. But it's a collection of not just orthopedic surgeons, but it's infectious disease specialists, it's radiologists. It's a lot of people to come together to help define infection. So in the International Consensus in 2013, we did something a little different. It looks very similar to Musculoskeletal Infection Society criteria, except for one thing. It's a change in leukocyte esterase. And you ask yourself, what is leukocyte esterase? Well, the interesting thing, it's a test that's very common. When you go to the emergency room, you take urine and you're testing for infection. Look for the strips where you dip it in and you test for infection. If you can dip it in urine, why can't you dip it in synovial fluid? So this is what the test looks like on the top here. So you have here the strips that are dipped in fluid and what the colors look like on the bottom. The box at the bottom shows 0, +1, +2, and the +2 is strongly positive. The downside about it is that the color strip test. So you look at the color and you determine if it's infected. Now what's the problem with that? If you have bloody fluid, that changes the test result. When looking at a study, it had high specificity but lower sensitivity. So what do we do to make it better? We actually take the fluid and we spin it down. Then all the red blood cells go to the bottom, and then we take the fluid on top and then test that fluid. That's the important one to look at. So we've looked at definitions of infection. The benefit of the definitions, you can do it in all countries. These are they're not available everywhere, but these are biomarkers that are listed in literature as indicators of infection. And this is periparasitic joint infection. We have serum, so from the blood, and then the synovial fluid. These are different phases here of different molecular markers that have been shown to be high in PJI. The problem is, again, they're not available everywhere. So we wanted to look at tests that were available in different places. So we already know about the blood CRP. Why not look at synovial fluid CRP? And so that's the test they did too, is we obviously know that synovial fluid white cell and polymorphonucleocytes are high. But if you look at synovial fluid CRP, it has increased sensitivity and specificity. If you compare patients who are not infected to patients who are infected, there's a pretty big difference. The problem in our hospital is when I try to send synovial fluid CRP, they said you can't send it because it's not validated. So then I just wrote serum on it and sent it, and it worked okay. So talk to your hospital before doing it, but it can actually be useful. The upside for it is that you don't need any special equipment, and you can do it in the clinical setting. But remember, it's not a validated test yet, so it hasn't been put in any definitions yet. So what I say is use it as part of your tests. Don't use it as your only test. Alpha defensin. I'm sure you guys have heard of this already, but it's not available in China yet. It probably will be over time. But alpha defensin is a reaction to an organism. So you have a bacteria, the neutrophils then release alpha defensin, and that release of alpha defensin is what is tested in the synovial fluid. When compared against a lot of other cytokines that exist, you can see alpha defensin here on the very top. The benefit here is you can see those who are aseptic or not infected is a very big difference from those who are septic or infected. Now compare these to the interleukins, where the aseptic or non-infected and the PJI overlap a lot, which is not good. The more separated you are, the better it is. How does alpha defensin do? Does pretty well. The sensitivity and the specificity are high in alpha defensin. The first one was done at the Rothman Institute where the study was the alpha defensin was founded, but it's been validated at other centers. In Europe, there's something called the Synovisure Diagnostic Confidence Stick Test. In the US, we joke that this is a synovial fluid pregnancy test. You know if you're having pregnant or you're not pregnant. Are you infected or not infected? So here, you put synovial fluid in the drop, and it tells you plus or minus. How does it do? It has pretty high sensitivity, pretty high specificity, but there's very few papers on it yet. The downside of this is you only get one test, just alpha defensin. It doesn't tell you culture, it doesn't tell you synovial fluid CRP, so only use this as a small part. In some states in the US, New York, you cannot use this, unfortunately. So again, just part of the process. The benefit is that it's a panel test. So in the US, when I send alpha defensin, I get culture, I get fluid count, I get everything together, and it emails me the results. But remember, it's an indirect measure. It's not direct measure of bacteria. It's an indirect measure of your body's response. Why is that important? Because if you take out fluid and it's negative, you come back next day, your body hasn't enough time to rebuild it. So you need to wait 4 weeks before you can test alpha defensin again. So that's the catch. So that's why for reimplantation, it may not be as good yet. Another good serum test is actually D-dimer. So D-dimer is used for pulmonary embolism, right? In pulmonary embolism, D-dimer is high, but it's an inflammatory reaction. Because it's an inflammatory reaction, it's an acute phase reaction, Rothman Institute, they looked at D-dimer and showed that D-dimer over 850 was good for diagnosing infection and reimplantation. During reimplantation, the problem with infection is you normally can't get fluid. There's not much in the joint anymore. So here, if you use serum, it's better. The other benefit of D-dimer is it's already available in the hospitals. The downside is it's not that sensitive and specific yet. So it's not been validated, but if you try in your institution, be different. There's a study here in China that showed that D-dimer wasn't as good in Chinese patients and fibrinogen was better. So different patient populations might have different results. So understand that the diagnosis of infection is multifactorial. You need to look at a lot of different aspects. You're not just looking at one lab test or just a history and physical exam. You're not just saying the patient looks infected, you need to put everything together. Why is diagnosis of infection so hard? Because of biofilm. Biofilm sticks to metal implants. And what happens is most human infections come from biofilms. It's only made of 15% cells, but 85% extracellular matrix. What is this extracellular matrix? I call it slime. It's basically something that covers the implant, and basically it's protective against detection of bacteria and treatment by antibiotics. So what happens to it? Within this extracellular matrix, you have something called cell-to-cell signaling. So imagine if you had people in a row playing a game where they talk to one another. The cells inside a biofilm are smart. They can communicate with one each other very quickly, and that makes it very hard to detect it. 2, they're very close to each other, so they can release molecules to neighboring cells, and by doing so, influence what they express. They can exchange plasmids. So in the bottom here, you can see this. One has what's called a plasmid, which has some either bacterial information in it or information that's biologic in nature. These two can connect through conjecture, and by doing so, they can spread information very quickly. So it's not just a slow process where you have to pass one information. All of a sudden, everything in the biofilm can be changed very quickly. Because of that, they can actually exchange plasmids for bacterial or antibiotic resistance and virulence factors. So that's what makes patients very sick. Finally, biofilms can become invisible. Why is that? What do bacteria do normally? Bacteria divide. As bacteria divide, antibiotics stop it. The catch is the bacteria there don't need to divide. So because of that, antibiotics don't stop it as quickly. The other problem with biofilm is that it's monomicrobial and polymicrobial. If it's just one organism, easier to treat. But when it's many organisms, it's very hard to treat. The traditional culture methods are not useful. When you culture bacteria, all you do is get the free-floating ones. You don't get the ones that are stuck in the biofilm itself. So how do we get the biofilm out? A process called sonication. So in sonication, you take LR, some people use saline, and they transfer it to a basin. You want to make sure you take out all your explants from your system. So for a knee example, you want to put out the femur, the tibia, and the polyethylene, not just one part. As you take them all out, you want to place them inside this lactated ringer solution. Note that the lactated ringer is sterile and the basin is sterile. So because of that, we want to try to minimize the organisms beforehand. So these are all the implants. It gets sealed and then transported to the lab. Once it's in the lab, it's a semi-sterile environment. Remember, they still kept it sterile, put something on it, and then you sonicate it. Sonicate it using ultrasound waves to basically release the bacteria from the biofilm. Once they do this, you want to take the fluid out under the hood. Remember, keeping it as sterile as possible. Once you put the fluid out, you put them and you spin it down. Because you want to get rid of most of the fluid, you want the stuff at the bottom of it, or the pellet. That's the culture pellet there. You can see that there, and that's where your organism should be. So once you take it out, you take the fluid and you pour it out. Remember, taking very good care to keep the pellet. And you concentrate and you plate that. Remember, that's where your organisms are. So you do anaerobic and aerobic plating, ideally for 14 days. And by doing so, you increase your culture yield. So that's just culturing. Then you can take these and you can actually use molecular methods such as PCR. PCR has been around for decades. It's not a new technology. But the benefit is if you have a little bit of bacteria, you can multiply it out multiple times to actually see what organism is present. The best way to do it is not to take every single bacteria and multiply it out multiple times. You want to take one bacteria and put one sample on a chip, and you can do 60 bacteria at a time. It has high sensitivity and high rates of culture, and they could even detect bacteria if the patient is on antibiotics. Why is that? Because remember, it just has to have the leftover DNA that's replicated, and then you can see what organism is present. What else can you do? If you want to diagnose infection, you can use something called FISH. So 16S rRNA is the same preserved functional segment in most bacteria. You can use it by imaging. So we've obviously multiplied it. Now we have imaging as a method where it highlights in red where the bacteria are present. Now, the key is to combine these. So if you combine it with PCR and sonication, you can have increased yield instead of just tissue alone. So you can see here with sonication fluid, higher sensitivity and higher specificity compared to just periprosthetic tissue alone. So Those methods are pretty sensitive, but not maybe sensitive enough. Some diagnostic tools are out there. This is called the IBIS T500. This was the original, what we call universal biosensor. It combined PCR with something called mass spectroscopy. What does this mean? You take your sample, you multiply it out. Then you sort them by their weight, knowing that different organisms have different weights. So if you look at the top here, these are all the organisms that it can detect. Not just bacteria, it can do fungus, it can do viruses, everything like that together. And it shows spikes. The spikes show what the higher mass is. It can identify all bacteria present in samples in less than 6 hours. It can detect genes that control resistance and has the same sensitivity to detect biofilm. Remember, biofilm is hard to detect as to planktonic or free-floating bacteria. This company was then bought over by Abbott. So Abbott now something called IBIS Plex ID. The problem is cost is very expensive. $450,000 per US dollars in a system. And now what they're trying to do is it actually detects it in multiple areas. So most hospitals won't buy one machine for just orthopedics. We're too small. But can they buy one machine and do diagnosis of infection for all areas? That's what this plans to do. So something to think of in the future, but it is a detectable device now. The other downside too is it's very big. You need big lab space for it. So it's not a small counter space. So what's another option? Another option is called next generation sequencing. What does that do? Again, it follows the same PCR mechanisms. You do PCR, use 16S, that same exact conserved area, and you go through something called ion torrent personal genome machine. So it's a high throughput sequencer, so you can put a lot of information through at the same time, kind of like the microarray from before. And these sequences are compared against curated bioinformatic data. That means there's a database of existing organisms, it compares it to it, and it tells you what's positive and what's your likelihood. So the problem in a lot of these, you get a list of 5 organisms. You don't know which one's most important. But in next generation sequencing, it tells you the highest weight. When we did a study at Rothman Institute, we found that 90% of culture negatives were actually positive on next generation sequencing. So the next time you get a culture negative result, think about different molecular techniques. So those are all very high-tech ideas, but I also believe in low-tech ideas. When I'm doing a debridement of infection tissue, where do I debride? The answer is use topical diluted methylene blue. If you're in the joint, you can prepare the dilute methylene blue, inject it into a knee or a hip, and then once you can do that, you can see all the tissues that take up all the methylene blue because of the presence of white blood cell, and then you know where to resect it. So how to diagnose infection? We've covered a bunch of different areas. What I'm telling you in the room is to come up with a new way to diagnose infection. The ideal test is a point of care test, meaning you do it at the bedside. It has to be low cost, has to be easy to use, has to be very accurate, and you want to identify organisms and antibiotic resistance because you need to know what to treat and what to treat it with, so which antibiotic to use. Use serum markers reimplantation instead of just synovial fluid. If you can come up with this, then you will make a lot of money and you won't have to practice orthopedics anymore. Thank you very much.